So we've been talking about hematinics. We classified hematinics as ion preparations, maturation factors, and adjuvant hematinics. So in this lecture, we're going to talk more about ion preparations. So ion preparations, the only use in pharmacology is for the treatment of iron deficiency anemia. So before these drugs are prescribed, one needs to um, address the underlying pathology, if any, for um, anemia. Okay? For example, in say developing countries, there is endemic infestations with hookworm or whipworm. Okay? So this infestations results in bleeding from the GIT, and that results in anemia. Okay? The other cases could be there could be uh, pathologies in the GIT, like untreated ulcers, or there could be malignancies, or there may be people with hemorrhoids. Okay? All this could potentially again cause bleeding, and that could result in anemia. Okay? Sometimes there could be patients presenting with hematemesis or hematitis, or there could be drug-induced anemias, for example, drugs like corticosteroids or NSAIDs, okay, like aspirin. So there could be drug-induced bleeding, and that could result in iron deficiency anemia. Okay? Or there could be abnormal bleeding, so there could be menstrual loss, menorrhagia, or there could be people who have undergone surgery. Okay? Surgery again of the GIT, like bariatric surgery, okay? Or removal of a part of the GIT. So all these things could um, cause iron deficiency anemia. Okay? So before the patient is treated with iron deficiency, with iron preparations for iron deficiency anemia, one has to rule out or treat the underlying pathology, if any. Okay? So only when these pathologies have been addressed should one go ahead and prescribe iron preparations. Okay? So that's something to keep in mind. Okay? When we talk about iron preparations. So remember again, iron preparations are only used in pharmacology for the treatment of iron deficiency anemias. So we're going to talk more about iron preparations today in this lecture. Okay? So these are agents from our previous discussion. You would know iron preparations are agents that are given for the treatment of iron deficiency anemia. Okay? So what are these preparations? So the iron preparations can be classified depending on their route of administration. Okay? So we've got oral preparations and we've got injectable preparations. So the oral preparations are the most commonly used and available are these. Okay? Okay. So these are the uh, available oral preparations. We've got ferric maltol, we've got ferrous fumarate, we've got combination drugs of ferrous fumarate with ascorbic acid and with folic acid. We've got gluconate, we've got sulfate, and we've got again a combination here. Um, and then we've got this sodium ferritate. Okay? So from this, what is clear is that we've got these oral preparations. We've got ferrous salts and ferric salts, and we've got combination drugs, combinations. So yeah, um, so the big picture is we've got oral preparations which are ferrous salts, ferric salts, and combinations. So from our previous discussion, it's pretty clear that the ferrous salts are more bioavailable. Okay, so that's why in the classification of the clinically used drugs, we've got ferrous salts predominating. Okay. All right. So ferrous salts and these oral drugs, they are absorbed similar to the dietary iron. So in the previous lecture, we've discussed the absorption of dietary iron. So you might remember we talked about how the different constituents of the diet containing iron salts are absorbed. So it would be a good idea to revise this part of the discussion. Okay. So they are absorbed, distributed, and metabolized and excreted similar to the dietary iron that we have discussed in the previous lecture. Okay. Iron, we said it's very reactive. It's got two oxidation states. You've got ferrous and you've got ferric state. So this state happens to be more reactive. Okay? And because of this oxidation state, iron can combine with lots of drugs and dietary constituents. Okay? So there can be drug interactions. Okay? So dietary iron, it can interact with food constituents and with drugs. Okay? So what are the important food constituents? The important food constituents are phytates, polyphenols, and can be calcium, and there can be the other important ingredients, tannins. So you remember they are present in tea, coffee. Okay, so these are the constituents in the diet with which iron can interact. Okay, so what happens is these substances which are present in the diet will oxidize the ferrous form to ferric. And this ferric form we've discussed is not very soluble. It's almost insoluble. So if it's insoluble, it's not available for absorption. So that's the problem with these drugs. So the best idea, and then calcium salts, in addition to being part of food, they also form part of, they also are present in antacids. So you remember antacids are salts of calcium, magnesium. Okay, so those are the divalent salts. In addition to food, um, the iron salts can interact with antacids. Okay. The other drugs with which iron can interact, in addition to antacids, are the fluoroquinolones. One of the most well-known examples of fluoroquinolones would be ciprofloxacin. Okay. It could also interact with tetracyclines, could interact with levothyroxine, and it could react with vitamin E. Okay. So those are the most important drug interactions. Now, fluoroquinolones, we know they are given for respiratory tract infections, urinary tract infections. Now, if there is a patient who has got already, who is having these diseases, and then they're being prescribed ciprofloxacin at the same time they've got anemia, and you need to give dietary, an iron, oral iron preparation, then what do? Obviously, you can't stop giving ciprofloxacin, right? So the solution is you space out the drugs. Okay, so you give iron preparation and you separate the other drugs in time. Okay, so after giving iron preparations, maybe after at least 2 hours. Okay, so after 2 hours, you can administer these drugs, these interacting drugs. Okay. So this 2 hours gives the body ample time to absorb whatever is there from the preparation into the blood. Okay, so that's one point to be kept in mind. Okay, so that's the solution for us. So yes, does iron interact with other drugs? Yes. Does it interact with food? Yes. So what can we do about it? We space it. Okay. Okay. Yeah. So remember this point. Okay. Iron preparations. Now there are these many clinically used iron preparations, right? So we've listed this big list out here. Now, why do we need all these compounds? Okay, so that's what we're going to discuss. What's the advantage or disadvantage of the different preparations? Okay. So we know the most common anemia is iron deficiency anemia, and it affects a large part of the population, especially in the developing world. So the most common iron preparation that's given for IDA is ferrosulfate. Okay, why? Because it's available, because of its availability. It's cheap in the sense that it's affordable, and it works, it's effective. Okay. So that's the reason why um, this is the most common drug given for iron deficiency anemia. Okay? But of late, there is lots of advertisement of sustained release preparations, enteric coated. Okay. So should this be in our list? We did not talk about any of these sustained release preparations. If you recall this list, okay, it doesn't have any of this sustained release or enteric coated preparations. Why? Okay. So the reason is, let's say, what's the reason? Okay. So, um, so the ferrous salt, it is absorbed predominantly in the duodenum. What's the duodenum? You've got this GIT, you've got the stomach, all right? So the stomach opens into the duodenum, okay? And then distal to the duodenum, we've got the jejunum and ileum, which forms this part of the small intestine. So small intestine, the different parts of the small intestine is duodenum, jejunum, and ileum. Okay. So iron absorption predominantly happens in the duodenum. Okay. So if you've got sustained release preparations or enteric coated preparations, so sustained release preparations are basically you've got coating on the top of the drug preparation, and that coating is supposed to be intact in the acidic pH of the stomach, but it gets degraded in the alkaline environment of the intestine. Okay. So if you consume enteric coated or sustained release preparations, they won't dissolve in the stomach. Rather, they would move distally, okay, and they get degraded beyond the jejunum. Okay, so when they disintegrate, they release the iron preparation away from the duodenum, maybe near the terminal jejunum or the ileum. Okay, so in this region, absorption is almost nil. So you don't derive any benefit from giving this preparation. So as healthcare providers, we should not be led by the advertisement, but by the science. Okay, so not a good idea. Okay, so yeah, for at this point, we wouldn't recommend sustained release or enteric coated preparations. Okay, so maybe if there is evidence that suggests that these preparations have got better bioavailability compared to the other salts, then that's a different matter entirely. Okay, but as of now, we don't recommend. Okay. Okay. All right. So we've seen combinations here in the list. Okay. We've seen a combination. So this is a combination, and this is another combination. Okay. So we've got the ferrous salt with ascorbic acid and with folic acid, and we've got another ferrous salt with ascorbic acid and folic acid. So why this combination? Okay. So iron salt plus ascorbic acid plus folic acid. Okay, why this combination? Okay, is there any advantage? So if we look at the second combination, so this is in combination, this is an iron iron plus the maturation factor. Okay, so this could be a combination that could be given in pregnancy. Okay, so you've got you take care of the spectrum of anemia of microcytic hypochromic anemia. So iron deficiency anemia, the RBC, the morphology of the RBC is microcytic hypochromic anemia. Okay, and if it's a deficiency of maturation factor, it is to be megaloblastic anemia. Okay, so yeah, so this combination is good for pregnancy. You know, yeah. So what about iron salt plus ascorbic acid? Now this acid. So in the acidic pH, we've got uh, ferric salts getting converted to ferrous salts. Okay, so that's the first reason. The reason number two is that um, at low pH, okay, so ascorbic acid has got a low pH, and you're combining it with the iron salt. So what happens is it forms a complex. Okay, so there is an iron salt ascorbic acid complex. Now this complex um, uh, so yeah, so this complex contains both ferrous and ferric maybe. Okay, so this complex with ascorbic acid, it remains soluble even at high pH. Okay, so the ferrous salt or the ferric salt. Now, ferric salt, if at higher pH, it becomes insoluble, right? But this complex with ascorbic acid is soluble even at high pH, and therefore that could increase the bioavailability. So, is there any clinical application? Certainly, yes. So, the iron salts could be administered along with maybe 500 units of ascorbic acid. So that we can increase the bioavailability. Okay. And so that's the reason for the combinations. So we've got a combination with ascorbic acid and we've got a combination with folic acid. Okay. So the third reason, there is a third reason as well. And the third reason why we use a combination with ascorbic acid is that phosphates. Okay. So when this complex is formed, there is also formation of phosphates of iron. Okay? So at this low pH, what happens is this phosphates also become soluble. Okay? So all in all, the bioavailability of the ferrous iron, it increases. Okay? So that's the whole story. Okay, so now we have established why we have the combination of ferrous drugs with ascorbic acid and with folic acid. Okay. All right. Yeah. So, yes. So how much iron should we give? So what's the dosage regime? What is the regime? Okay. So remember, the dietary requirement in normal, so it's very difficult to define what a normal human being is, but in this context we're talking about people without deficiency. Okay? For them, the requirement of elemental iron is 1 milligram for males and for females it's 2 milligrams, and in pregnancy, lactation, this would be 3 to 5 milligram of elemental iron is required per day. Okay, but in deficiency states, what is required is 100 to 200 milligram of elemental iron. Now, in the deficiency state, this cannot be met by the diet. This requirement of elemental iron cannot be met from the diet. Okay. So the reason being, in a typical Western diet, around 15 milligram of elemental iron is consumed per day. Okay. Of this, what is absorbed is about 10%. Okay, so that is roughly 1.5 milligram, and that is approximately the daily requirement. Okay, so a person consuming 15 milligram as part of the diet, in what the body gets out of that is 1 milligram of elemental iron, because only 10% gets absorbed. Okay? So this is for a normal diet. Now imagine the person needs to get 100 to 200 milligram of elemental iron per day. They've got to really consume lots of meat, which is, physiologically almost impossible. Okay, so the only recourse to replenishing the stores in iron deficiency anemia is to give it as drugs. Okay, either oral or parenteral. Okay, so which means we need to know just how much of elemental iron is available from this various important formulations. Okay. So let's here probably yeah. So let's look at the oral preparation. Let's look at the dose in milligram, and let's see the amount of elemental iron. And let's fill up the preparations. So let's begin with ferrosulfate. So ferrosulfate, say for 300 milligram preparation, you get approximately 60 milligram of. So this is in milligram. Okay, that's in milligram. This elemental iron is in milligram. So out of 300 milligram, you get about 60 milligram of elemental iron. So there is another preparation, ferrous sulfate, which is desiccated or dried. Okay. So desiccated, if you give 200 milligram of the desiccated, you get about 65 milligram of elemental iron. Okay. So if we look at ferrous fumarate, this is again a 200 milligram dose, and out of that you get about 65. And ferrous gluconate, if we look at ferrous gluconate, so that's again 300. So from 300 you get about 35 milligram of elemental iron. Okay. All right, so why is this important? Why are we concerned about this? Now think about this. A person, so So ferrous sulfate is administered TID, okay, 3 times a day. Okay, so let's say 300 milligram. 300 milligram is administered TID. Okay, so the person consumes a total of 900 milligram in a day. So that brings to 900 milligrams per day. Okay, so in this 900 milligrams, you'd have about 180 milligram of elemental iron. Okay, so remember, what is the requirement? The requirement for replenishing the stores is 100 to 200 milligram of elemental iron. Okay, so here you get 180, so you satisfy the requirement per day. Okay, so this is the reason why ferrosulfate is given TID 300 milligram. Okay, all right. So remember this point. Okay, so we are giving this drug orally. So why do we have all these preparations is the next question. Okay, we've got umpteen number of ferrous preparations and ferric preparations. So why do we have this large number? Okay, so we said the most common one is ferrous sulfate. Okay? But if we give ferrous sulfate, it has got if we give ferrous sulfate in therapeutic doses, okay, we are giving it at this regimen, then in most of the people there will be side effects. And what are the side effects? We'll have epigastric pain. Okay, we'd have again a GIT manifestation, nausea, vomiting, again, sorry for that. Okay, sorry for that, please bear with me. Okay, so we would have GI manifestations, which is epigastric pain, have nausea, have vomiting, and sometimes people have constipation. Okay, so this is what people experience. And sometimes it is so severe that they stop taking the medication. Okay? So there is reduction in compliance. Okay? So that results in therapeutic failure. Okay, so how do we address this issue? So what has been observed and documented is that these GI manifestations, these side effects, is directly proportional to the dose that is consumed. Okay? So if you've got ferrosulfate in this dosage regimen that you're giving, it produces this. The solution could be you could reduce the dose. Okay? So you could do that either by physically reducing the dose, or you could administer it along with food. Okay? So the solution would be, since this adverse effects is directly proportional to this dose, the solution for the problem would be to reduce the dose, or administer the dose along with food. Now, when you combine the iron preparation with food, you give it along with food, there is almost 30% reduction in bioavailability. Okay? So that implies that you have reduced the dose, right? So it would be better tolerated. Okay? So you've got these preparations which have got lesser dose than ferrous sulfate as such. Okay, so if we look into this table out here that we just wrote some time back, we've got this salt. Remember this salt, ferrous gluconate, right? Ferrous gluconate. It's a 300 milligram tablet, but it's got only 35% of elemental iron. Okay, meaning it's got less dose of elemental iron coming in, and therefore it would have less GI side effects. Okay, so there are multiple doses of there are different doses of elemental iron that's obtained from the preparation, so one should know why we have that. Okay, so the reason is that reduced dose you'd have lesser side effects. So if it's better tolerated, then the compliance would be higher. So that's the therapeutic advantage. Okay, but we could bring about the same effect with ferrosulfate by giving it along with food. Okay, so that's the solution. Okay. The other thing that could happen is after this, when you pass out, so you take ferrous salts and you pass the fecal matter out, it's seen that there would be black stools. Okay. So this could be a concern to some patients. They might be unduly worried about it. So we need to counsel them that if you take this preparation, there is likelihood of black stools being formed, and it's nothing to worry. Okay, that it's an expected side effect. It's an expected observation. Okay, nothing to do pathologically with their body as such. Okay. Okay. So yeah, so we should make sure that this fact is made aware to the patients to whom we are prescribing. Okay. Okay. So we talked about acidity, right? About phosphate being soluble. Okay. So yeah, so in absorption and in the absorption process, we have to remember that at low pH there is maximum solubility of the iron salt. So as it comes into the duodenum, the solubility of the ferrous salt decreases because it gets converted to the ferric form. Okay, so that's an important point that we need to keep in mind. Okay. All right. So yeah.